Good afternoon, everybody. Now, when Dr. Gopal sent me this topic that you guys have to talk on which is the best injection for me, I was a little puzzled. Does it have to be the best for me, or does it have to be best for my patient as well, or does it have to be the best for both of us? I have no financial disclosures to make. In a lot of disease, when more than one agent can be given for a particular indication, and you offer the patient that you can get this, you can get this, this is the side effect, this is the pros, this is the cons, he ends up like this. He doesn't know that on the other side of the table, even the doctor and some of the best men in the world are also confused as to what is the best injection possible. Now, there's no one set criteria that there's no one size fit all approach. You have to tailor your approach when you are selecting an injection for a patient. Now, what are the factors that impinge on your choice? The science behind it. In talks like this, when we read journals, there are a lot of science which is coming in on the agents. Good quality trials are happening. So, we need to know about that. We need to know the patient profile. We need to understand the profile of the patient before we think about giving him a particular injection. We need to look at the pathology that we are dealing, what is the possible pathomechanism of the disease. We need to have his previous treatment history, if any. We need to know the magnitude and the morphology of the edema that we are treating. We need to assess his ability to follow up and his motivation. And of course, in our country, like Dr. Said, economics is probably one of the most important factors. Now, we'll be looking at each of these factors in a little more detail. But first, I'd like to present a case scenario. Now, this is a 47-year-old multinational company executive, a high executive for that matter. He's a biker, avid biker. He travels around quite a bit. He developed a CRVO in his left eye with macular edema. His vision dropped to 636 N18 and his IOP was 20 mm at the baseline. So before he came to me, he had received 8 injections of anti-VEGF and 2 injections of IVTA. Every time his macular edema would go away, his vision would improve to 612, and then as the duration of the drug got over, the macular edema would come back again. So this is when he presented to me. These are his previous OCTs. He was a steroid responder who was controlled with a single drop, and of course he developed cataract after the 2 IVTs, so he underwent a cataract surgery as well. So I have a pseudophakic patient, a steroid responder with a CRVO who is very active, and he does not really want his lifestyle to be affected too much. Now he is with me. Me means not me, macular edema. So what do I do? What goes through my mind? First is the science. We need to look at the indication for which we are considering the injection. In a uveitis, considering anti-VEGF is not probably the best approach. In a pseudophakic CME, you would not want to consider anything other than a steroid. But in a BRVO or a CRVO, you would want to consider options. Both the steroids are on the table, and so are anti-VEGFs. If you are considering AMD, obviously steroid is the last choice, and the first choice would be anti-VEGF. You need to look at the data in the literature on the efficacy of these agents, because a very good number of trials are available. You also need to look at the evidence of, whenever you have more than one choice, you need to look at the evidence of superiority or non-inferiority of the choices that you are considering. So you need to look at the data. In our particular case in CRVO, there is data which says that both steroids and anti-VEGFs work quite well. You also need to look at the patient profile. You need to look at his activity levels, you need to look at his lifestyle, and of course, you need to look at his susceptibility to complications. Younger patients are more susceptible to glaucoma. Younger patients with a clear lens are susceptible to developing a cataract, which an older pseudophakic individual is not. This is another very important factor when you are choosing a agent, phakic status, whether the patient is phakic or pseudophakic. If he is pseudophakic, the bugbear of cataract is totally gone away, so you don't need to bother too much about it. Whether the patient has a clear lens or a cataractous lens, even if he has an early cataract, you're not doing any crime by increasing inducing the progression of a cataract. But in a clear lens, if you have caused a cataract, you have done something wrong. You also need to know the implications of cataract surgery. There are a lot of people who would say, fine, if a cataract develops, I'll operate. In an AMD patient, if a cataract develops and you remove the cataract, no problem. But in a DME patient, if you operate upon him, it can worsen his macular edema, it can worsen his diabetic retinopathy. So you have to consider that as well. Now, in this particular case, my first choice was anti-VEGF. The patient's first choice was Ozurdex because he wanted less frequent visits to the hospital. So we gave him Ozurdex. He received 3 to 4 monthly injections of Ozurdex for the past 2.5 years. He's happy. He maintains a vision of 612 N8, and he's very well controlled. He was already pseudophakic, so cataract is not my problem. He is already very well controlled. He's a steroid responder on one drop, which he does not mind putting it, twice a day. So that was the treatment in this case. Now coming to another case, this is a diabetic macular edema case, slightly more trickier to handle than CRVO. This was a 58-year-old female with moderate to severe NPDR with no renal impairment, severe macular edema with prior laser. She's had one laser, she had 2 or 3 Avastins and 1 IVTA, all patchy, not very regular, 2-3 months between injections, and every time the macular edema will come back again. She's not a non-responder, she is a responder every single time she responds. Now at presentation when she came to us, 660 vision, N36, IOP was 18 mm. Now FFA, because she did not have a renal impairment, we did FFA, showed diffusely peripheral CNP areas. So in this particular patient, apart from the factors that we discussed earlier, there are certain other factors that play. Now, whenever we are choosing an injection, we need to look at the pathology. CRVO has VEGF levels 10 times that in diabetic retinopathy. Diabetic retinopathy has VEGF levels 4 times that in a normal individual. So VEGF is a very important factor that we should consider neutralizing when we are trying to treat this particular edema. If you are going to treat a uveitic macular edema, of course, VEGF does not have a role there. It is basically inflammation. You need to know the natural history of a disease. A pseudophakic CME is a one-time event. So if you give one injection, end of story. A diabetic retinopathy or CRVO is a continuing long time of treatment. So you need to make sure that that patient is going to be able to follow it up. Also, you need to know that there are certain agents like anti-VEGF which modulate the basic pathology. Anti-VEGF injections are known to cause some amount of regression of the diabetic retinopathy status per se. So they are probably a better choice in these indications. When you are looking at the previous treatment history, you need to know whether lasers have been used, what is the RP status, anti-VEGFs have been used, steroids have been used, what was the dosing, was there a response to begin with or was there no response, was there a break in the treatment or was it a regular treatment and failure, what was other concomitant treatment that was given to the patient. Now once you have all these factors, you can choose your injection better. Of course, you need to understand and the patient needs to be told the posology or the dosing. You cannot tell a patient that you need 3 injections and your macular edema of diabetic origin is going to go away forever. You have to tell him that you need 8 to 9 injections in the first year, 3 to 4 injections the next year, another 2-3 injections in the subsequent years. And if the patient is willing for that, fine. If the patient is not very willing, then you have to consider treatment which is used much less frequently. You need to know his ocular status and compliance history in the sense that if this is a patient with a bad PDR, he is probably not a person who follows up with his ophthalmologist or with you very regularly. So you need to choose a treatment that does not require repeated visits to the office. You need to make sure that the patient understands, is motivated and has a social and financial ability to embark on the treatment that you choose for him. Of course, in our country, this is probably the most important factor. The 1 year, just as a representative example, 1 year cost of treatment of DME, if you do it the ideal way, Avastin costs this much, Lucentis or rather now Eccentrix costs about 3 times as much, Ozurdex is a little less than that, and Eylea, of course, not been released yet, but I'm sure it's going to cost a lot more. So in this particular case, in our second case, we counseled her about the role and of course the dosing, that you have to be regular. Patient was motivated. So we embarked on anti-VEGF treatment. Patient received 3 loading doses and after that PRN, and she's received about 14 injections in 3.5 years. She maintains reasonably decent vision. This is her last OCT. Her IOP has not changed. We have not disturbed the lens. The lens is clear as before. So the next time before you rush to inject, there are a lot of factors that you need to consider. There is a lot to contemplate. Think about it. Choose the best injection that fits your patient. Don't go by just guidelines that in particular indication only this is required. You have to be a little flexible so that both you and the patient end up happy. Thank you.